since this afternoon we're going to talk a little bit about Ebola. I haven't got a slide deck prepared. I think we've all been inundated with endless information. You can't turn on the television, the internet, pick up a newspaper without anything about Ebola. You think it's the only thing happening in the world. That was, the recent election. But I wanted to take the opportunity to have a conversation and chat about some of the worries, because it engenders a lot of fear. Not entirely unreasonable, but being afraid by itself doesn't help us. So I think being aware of what's worrying and what our concerns are and what our actions are together will help to alleviate that concern and make us realize that it is something manageable. I mean, if I was asked, to go and look after a patient with Ebola, I would be frightened. I admitted wholeheartedly that I would be, okay, what am I doing here? And I'm trained to do aseptic technique to a pretty high standard. In laboratories and microbiology, you're always trained to think about where your hands are, where did I just touch, and where are my hands going, and what could be. And I do a lot of that, and even so. I have worked with viral hemorrhagic fevers. I had the pleasure of working in Kosovo after the war, and they have a version called Crimean Congo hemorrhagic fever. And it's vector-borne, so it's transmitted by insects, but it is infectious from person to person, and it's quite dramatic. Not quite as fatal as Ebola, but it's nothing to toy with, and it's quite a dramatic illness. All the hemorrhage and the symptoms, and farmers would come from rural areas in with this horrible disease. And there were actually nosocomial cases in the hospital in Kosovo where I was working, and it was an extraordinary experience. And they didn't have a lot of PPE. We shared gowns. You got a glove. A glove, so you got a glove. You reused it. That's all you had. So I had some experience with it. Ebola has, what my biggest concern, and I think the biggest thing about controlling Ebola is what we're doing in West Africa. And the effort has been acknowledged to have been underpowered, and we're paying a price for that. They're paying a price for that. And what's happening on America isn't even on the radars of what's going on. There are over 10,000 cases, roughly 50% mortality, or higher, which is lower than has been recorded at other times. It's been as high as 90. And it appears that of those very few cases that have been in North America, the mortality is lower because of the supportive care we can give you without specific therapy. But in my own view, the effort of the international community has been underwhelming and disappointing and sad, because we really do need to have, and what that consists of is an awful lot of people who need the basics of controlling infections, which is finding the cases, identifying them, isolating them, and educating. It's not, you don't need a monoclonal antibody and a PCR machine. You don't need any of that. You just need shoe leather epidemiology on the ground to do the basics and good infection control. However you do that, for the heads of our nations, it has to be, I think, military and other, pouring people in. And if you're interested in doing this, there are all kinds of call-outs to all professional groups to join in. Okay, through the Red Cross, through Médecins Sans Frontières, anywhere, all of our professional societies are calling us and asking us to participate. I've had the same call. It's gut-wrenching. Should I do this? Can I do this? Very personal, difficult decision, because we've all got day jobs and things we're doing here. Our event on Thanksgiving went quite well. I did very well. And I'm very pleased with how it went. I'm proud of the fact that an awful lot of effort went into planning by our infection control team, occupational health, and a whole bunch of other people from Merge and elsewhere to be as prepared as you could be. It wasn't perfect, but you arrived, you kind of knew why he was there, and he was in. We have a beautiful facility, and he was isolated, and he had chronic diarrhea, right? But all the right things were done in the right order, in the right way. So it was very well done. What we didn't account for was the media frenzy. It was quite spectacular. Before we had even discussed it, really amongst ourselves to kind of get our messages together, sitting in Susan Rose's office, her phone was red hot, ringing, and every media outlet. She picked up one line, this is CBC, she picked up the other one, it was CTV, Global, and it was just, they knew before we knew almost. So it went viral. So it tells us in the world of social media, with something of that order of magnitude, that it will. So we have to manage the communication piece. And that's part of the fear. Why would we have had the biggest news conference in this room that Truth Monroe and her has ever had? this look like, you know, a news conference for the Prime Minister or something, you know, I mean, not that order of magnitude, but it was huge. There were 20 odd of us or something. And again, I think it goes to the whole fear of the unknown and the fear of Ebola and the magnitude of the concern that people have. The nurse who defied the isolation order went on her bike. Reporters were running after her. That was hysterical. That was in particular, it was in the States. Maine. You know, good for you, you know, because I don't know what happened ultimately. There's no reason to isolate. It made no sense. So I think that what I'd love to chat about is, you know, what are our concerns? I'll just remind you the structure, how it kind of comes together. You have the World Health Organization, and then you have the International Health Regulations. They describe how things happen. They get better and better and stronger and stronger. There's always been a worry after things like SARS that, you know, countries wouldn't report. Well, there's less and less tolerance to that, and the social media makes it almost impossible to get away with it. Some countries can try, but it isn't going to work very well anymore. From there, each of the member nations, and as a member nation of the UN, has their own public health agency. We have the Public Health Agency of Canada, federally, FAC. We have a chief health officer, a large infrastructure, and we have the Canadian National Microbiology Lab in Winnipeg, which is a state-of-the-art, world-class facility that can work with Ebola. And they have strategically brought people in to do Ebola work, and we should be immensely proud of that, because they have developed some of the vaccine candidates and the treatment candidates that we're developing. So that map always wants multiple people involved, but that had a big Canadian. And the testing was done on monkeys and primates in a primate lab in Winnipeg. It's the most expensive laboratory you can imagine, because it's very expensive to do that work, as you can imagine. I got to tour it twice, when it was being built and when it was finished. And it was being built, I got to see the type of concrete, where the concrete emerges with the floor, the seams, so you can't get a leak, and they thought of everything. It's a very expensive facility. But, you know, so we can be rightly proud. So Public Health Agency of Canada has, you know, contributed that way and in other ways. Because it's international, they have jurisdiction. Then it goes to the province. We have the chief medical officer. Right now, we don't have a chief medical officer. It's Dr. Mowat, who was the medical officer in Kingston for years, and who had other jobs. He's been past acting chief medical officer, very experienced guy. He's the acting chief again for Ontario. So you can't get anybody who doesn't know this better than him, very knowledgeable. And he's working through the ministry. Remember, after SARS, we built Public Health Ontario, an agency. And that agency's in downtown Toronto. And they are kind of the think tank. They have a provincial infectious disease advisory committee. You know, it was PIDAC. I formed PIDAC, chaired it, was in the ministry, to the agency. It's still very functional. Recently we had and then we have our local medical officer in each of the regions. We have 3 health units. Dr. Shabas is our medical officer. So we work, that's the chain of command. And we work through them on this because it's a very notifiable disease. It's covered in law. So, you know, we aren't freelancing any of this. You know, to dream up these ideas of what to do. We're following a standard protocol. We look at the CDC and what they've done. They've learned a lot with their cases recently in the States. And they put out new guidelines. We learned something last week, and they updated everything. They went to town on it. It was really interesting. The level of depth that they're putting into this. So we have a lot of resources to help us understand what we're doing. So I think that the event went very well. We notified, you know, we got a call at 3 in the morning. People got called from Emerge to, we called Dr. Shabas, we called the health unit, they called the feds, you know, and so on. It went as it should. So it works. But because we had done all the work in advance, we knew exactly who to call. Because when we tried the emergency number out the first time, it was a wrong number. So we had, you know, good thing we did all that. Because at 3 o'clock on Monday morning, on Thanksgiving morning, you don't want to get a wrong number. So we did all of that work. Things that we are looking at further is how do we now interact as a region, right? Because the chief medical officer put out a directive. They rarely do that, but he has that authority to say, you're doing this because I say so. And it's something in your box, what to do, right? So he put out a directive. They had a few areas we were concerned about. You know, everybody wearing PPE and triage all the time. It's not quite what they meant. You know, look, we got that sorted out. It's not plexiglass. So they come out yesterday with version 2, the update. They clarified some of the ambiguities. So it covers off all those areas. So we know exactly what's expected of us. The planning has been pretty intense. We didn't train absolutely everybody because it wouldn't make sense. You're not going to see a case of Ebola on 25. We're not going to admit you. You're staying immersed. And now we have confirmation. What we did was exactly the right thing. And from there, a patient who really has Ebola, clinically or with a blood test or both, is going to Kingston. Because they've been designated as treatment hospitals now. The minister made that call. Minister Hoskins. Our minister, Eric Hoskins, is a physician, he's a public health specialist. He knows this stuff very well. And our deputy is Bob Bell, an orthopedic surgeon. So we've got, good people who understand this stuff. So we're going to be moving, they're working on the transportation, we're going to move the patient, move them once. They're in our merge, and they have Ebola, we're going to move them to the designated treatment site, which is Kingston, once, in a very specialized ambulance. They're still working that out. That unit's going to have to be set aside and disinfected, and that'll be interesting, and how they're going to do that. And we wouldn't move somebody within the organization. Triage, isolation room, that's it. You have a washroom, for exactly that reason. The details of the personal protective equipment have been debated. You've heard the debate, what happened in the States. They've updated their protocols, and we've provincial directive. It kind of looks like there was some borrowing there, which is great, And even the U.S. is crowdsourcing new ideas for personal protective equipment, which I thought was really smart. Some brilliant person out there has the answer. And our the PPE is full body coverage. You can do that with different styles. There's the suits you've seen, the white suits that cover up everything with the hood. Oh, there's ones without hoods. There's ones with shrouds. We've gone to chemo gowns, which are waterproof, with the leggings and double gloves and the visor. The goggles are considered optional because they fog up for some people and make it worse for you because you're touching them. And then you can't do your job, so they're kind of optional. If you think you want to wear goggles, fine. If you don't think you want to wear the face visor, N95 respirator. Ebola's not airborne. It's not airborne. It's droplets. But they're putting in the N95, and let's not have that argument because it just doesn't get us anywhere. And all of that, and then a buddy to watch you, two caregivers, especially when you're taking this stuff on. It is the doffing, the removing of the PPE, which is what everybody is concerned, right? And if, for those of you, anybody here had the formal training for the SARS or the Ebola PPE? Yeah. Tricky to get up, right? Tricky to get off and do it right and not contaminate yourself. That's where the CDC went and recalculated it. They've added all these extra hand hygiene steps at each point. You take out one thing, hand hygiene, but it's not hand hygiene, it's now glove hygiene. Because they did something that shocked us. They said, you're going to take alcohol hand sanitizer on your gloved hands and do that. If you had done that at any other time, we would be giving you a fine or something. You never do that. You always put the alcohol on your hands and between your hands. Now they're doing it on gloves, and everybody did a double take. But it's not hand hygiene, it's glove hygiene. It's cleaning the surface. So every time you remove one thing, you clean the gloves. And then there's 2 layers of gloves so that you can, before you touch anything around your head and neck, which is the place you're going to contaminate, you're going to use a clean pair of gloves. And so it's a lot of stuff you need somebody just like learning to line dance. This foot go here, this foot go there, kind of this hand go there, do this is how you're going to want to do that. So we're working on the training and emerge to get everybody up to speed. It's a challenge, right? Because the emerge docs, there's a whole bunch of them. We're working with EMS to try to arrange that anybody who we can figure out, if somebody phones an ambulance and says, I'm feeling rotten and I was in West Africa, and EMS says, okay, we're taking you not to Bancroft, we're not taking you to Trenton, we're going to Belleville, unless there's a real strong reason not to, because it's just easier in one side. That's kind of where things are at. If vaccine trials are underway, if there's an outbreak, that's the time to do vaccine trials, and the clinical trials for ZMac are underway, and other related drugs. So we hope that those they have very high probability of being successful in my team. So I'll stop there. That's kind of a brief kind of state of the union as I see where we're at. We are well prepared. And I think we need to just highlight and discuss, any issues you have. I'm happy to field whatever questions I can to put you at ease. But you have to respect what you're doing. Absolutely. Because it is a very virulent virus and transmit. So I'll open it up there. Natasha?
I'll stop.
I may sit down because I've got knee issues. That's okay, I'll sit down.
My question's related to other outpatient areas other than the merge.
Yeah.
So I'm looking at for example, the Rehab Day Hospital, which is our receptionist sits right at the main entrance for SILS 2.
Yeah.
What are the things that we should be doing, if anything? I mean, should we be asking our new patients the questions, have you been, in those countries in the last 30 days, and if you're...
We should be, in my opinion, I think we should ask, we ask patients, are you allergic, what 18 times, right? I think we should be adding to that some important questions. Where have you traveled? Because it could be relevant, particularly if they have infectious symptoms. So have you traveled? You can ask it in a manner that seems almost sociable, but have you traveled anywhere in the last month outside of Canada? Is the way I ask the question.
Okay. And then what do we do? Say someone says, yes, I have, I was in West Africa, and actually, and they're actually standing there.
Yeah. So
what should we do?
Well, I'll just jump in because this morning we were at a meeting and we had put a process in place with this Natasha for outpatient areas. We want to take that very closely. There will be passive signage for people talking about travel, talking about being unwell. And what we've decided is that there will also be masks at every outpatient area, so that in the event you get someone with fever who's been in West Africa, they will be instructed by signage to don a mask and go to the
and it's no different during the flu season, cough and cold season. We should be having that PPE there, with hand hygiene. Somebody's standing in line coughing their head off. There's a mask or some alcohol. At all, and the travel history is based. Remember, someone coming back with that history most to have malaria, which you don't want to miss because it's entirely treatable, but can be fatal if not treated. Or they could have typhoid fever, salmonella, bacteremia, bloodstream infection. It could be very, very sick, very diagnosable, very treatable. You won't know unless you ask. People travel all over. Who here in this room has traveled outside of Canada at least once in the last year? Well, half is more than half of it. So.
At our Department of Medicine meeting 2 weeks ago, Mike Delaroche gave us an update, and he indicated that CFE Trenton had made almost no preparations at that time, and he felt that that was a very weak link in the treatment. And has anything been done in the last couple of weeks?
Yeah, so the individual was, we weren't allowed to say that initially, right? The Surgeon General himself said, no, we can't talk about that at that moment, that Sunday, but later on, they said, yeah, he was received from Trenton. And so, yes, they were here when he was here. They came, and they said, oops, sorry, and we fixed that. So we're looking at where they fit in the regional plan, they have great resources for this sort of thing too. So they are doing, delivering supplies is all they were doing, and all they are going to be doing. They're not in the hot zone, in the airport, but there's local people there. So he was ultra low risk, but he was a good driver. So there's been several meetings, and tabletops and planning, look very good at that. So
Yes.
Just to clarify, I think the glove hygiene comes from the CDC, the American guidelines.
Yeah.
At this point, I don't think we've adopted that in Ontario and specifically here.
I didn't see it, no. It is an interesting one. I think there's conversation. I read it and I went, oh wow. And then I read it again, I don't know what does the glove, you take the gloves off. Anyway, conversation we gotta have. What I feel is disappointing is the lack of research in this area. That's distressing. I mean, it's so important, so basic. Think of all the millions of dollars spent on personal protective equipment. I think it deserves a little more research. to that level. Is anybody here involved directly or nearly directly with the event on Thanksgiving month? Did that emerge? One is everywhere.
Of course.
Where do we stand with vaccines and drugs right now?
Fascinating. There's about 15 vaccine candidates. Several of them are a vaccine inside a virus. So we actually give you a virus, and it's the newest way of delivering these kinds of products. And it's in the vesicular stomatitis virus. So you see VSV, and I have to do a double take that I wasn't VZV, which is Zoutman, easy chickenpox. That's great. No, the vesicular stomatitis virus causes ulcers in cows, and because of a process that the cows can't feed. It's not infectious to humans in the slightest, so it's a modified version, but they genetically encode the vaccine inside the virus and give you the virus. It grows once only, one replication only, and they don't go any further. But then your immune cells, as they go after the virus, then start making the antibody against the antigen, which means you get immunized. So I believe it's delivered by inhalation, oral inhalation. It's not even given as a needle, which, from the mechanics of giving it in rural areas like Africa, is totally brilliant. But Canada ever roll in that? So, and there's a bunch of other vaccine candidates. They cover multiple strains. The monoclonal antibody, the Zoutman or ZMapp, as the Americans call it, is, as you know, we're using monoclonal antibodies to treat all sorts of inflammatory conditions and now infectious diseases. And they're an antibody, that is customized against what you're trying to shoot at. Is the golden bullet, and it is highly effective. The survival rate in monkeys who got Zoutman, even after they've been infected with Ebola and were very sick, was impressive. It wasn't 100%, but if they ate it before, 100% virtually. Very, very impressive. Now, they do like 6 monkeys. It was so expensive to do that work. Very impressive work. Yes.
When we dealt with SARS, the doors were all locked in on and there was no screening people. Is that something that would happen in an Ebola type situation, or?
Depends on the nature. Let's hope that we don't ever get to that point. We're not doing well if we get to that point of Ebola in North America, right? I think we got a sustained spread. You would go there if that happened. I can't imagine it ever getting that point. It just doesn't make sense. That's what they would be doing in Africa if they had those resources, but not doing this. But I think asking the travel questions is absolutely vital. Just like, are you allergic to anything? And what is your name? Your 2 identifiers. Yeah, go ahead and try.
No, it was just a follow-up with the suspected case that you had here. Like, when we have a suspected case,
Oh.
why wouldn't you do it in that situation?
If we had a suspected case, certainly the area where that patient's being managed would be secured.
Okay.
Yeah. If they're not moving anywhere, right, then that shouldn't be an issue. If you were the Ebola treatment hospital, it gets a little more complex. But again, this is the area where the patient is going to be, has to be completely secured.
If you went down actually to a lunch, there was a security guard at the desk blocking the door and to patient was being cared for. So there's no one there at least they need to be secure.
But family members could come
Yeah.
from the outside, potentially through the waiting room, to that point to ask people, or.
Yeah,
Right.
so the public areas.
And it's not how many members would be infected, so it's the disease themselves. Scott?
I was just going to add that in addition to what Lisa said, we know Markle and G4S, we do have a plan in place should we need to return to a SARS type situation where we'll restrict the access to the hospital. The kind of informal bad joke we had when after our suspect case was the security guard in the ER was the least busy person in the hospital because nobody wanted to go to that area.
Yeah. Exactly. And but everybody wants to hear about it in the media, but nobody wants to go over here. Exactly. 100%. Yeah, that's not.
Are you comfortable discussing what you think is going on in West Africa, and if you think we're turning a corner there?
Yeah, I think before you walked in, I mentioned that it's been widely acknowledged, even by the WHO, that the response was too little too late, and we're trying to play catch up now. We've never had, remember the prior Ebola outbreaks, there's been many, we're in tiny little communities in rural Africa, there's nowhere for it to go. Right? There's just nowhere it can go. So it can kill half the people in that community or more, which is catastrophic. But then it burns itself out. It can't go any further. Those that survive are immune, and that's it. In fact, this happened in urban areas is the problem. In slum areas where infrastructure is poor and the healthcare system is very weak. The Liberia's healthcare system is stressed beyond all belief. It's virtually collapsed in a way. It's having to be propped up by lots of foreign nationals, isolated people who do all this. So, what would I do if I was in charge of this? I would want to have, I don't know how many thousands of soldiers you want to have, doing the case finding, the case isolation is simple, in theory, difficult in practice, and to build isolation hospitals, they're not, and they're temporary, whether they're tent-based or 2x4s in plastic or whatever works. And they're doing that now. Just it happened all the time. Anybody on the OTN in Trenton? Anybody in Trenton?
Yes, we're here.
Any questions or comments?
No, I don't think so.
Okay. Feeling safe, feeling prepared?
We're glad you're coming to Belleville.
I can't promise that we'll do our, that's our intention. It may not all, someone could walk into a merge, wouldn't have called EMS, here I am. That's what happened to us, right? That's what happened in Belleville. In Picton?
No question, thanks.
Okay, and in Bancroft and at the hospital in Bancroft?
Hi, Janice in Bancroft. I just had a question about if we got to the point of intubation, what is the protective equipment? Do we have anything else?
Right, so we hope that we would never get to that point where to transfer somebody out. So it's remote, to say the least. That intubation would be, what they're recommending is the full PPE in a negative pressure room. Well, we're always going to put them in a negative pressure room anyway, so we've already got that covered, even if they didn't need intubation. And the glide scope and the other techniques that we use to make doing intubation easier should help reduce any spray. The person doing it, the physician, quite likely, would have to have the full PPE on. People have talked about whether you need a powered air purifying respirator or a PAPR, and that is that that single piece bodysuit associated with a headpiece. It looks like a bicycle helmet, but it's got a ventilation system built into the top, usually at the top of the helmet. And then there's a big shroud that covers your head and a big bubble. You look a little like a space person, right? An astronaut at that point with double gloves and the booties and all that. There's another version where the hose comes out the back and there's a ventilator system that hangs on a belt from your hip, which is less desirable because it's kind of exposed. We've had PAPRs. We bought them during the SARS events. They never got used and they're all outdated. They're gone, yeah. So we don't have PAPRs. We have the full PPE. And again, that's one of those situations that, that's one of the things we still have to contend with a little, make a decision. Because that formally in Ontario just came out today or yesterday that you could consider a PAPR. You don't have to. So you go with the standard PPE we've already talked about for Ebola, or do you want to go with the PAPR? You have to get in the suit. Well, that's fine. You're not going to contaminate yourself getting into it. You're doing that, so it's getting out of it. And training and all of that. Or do we go with what we know works and can we do that reliably, consistently? And would it be better to do that?
Lisa, can you talk up a little bit just for the sake of
Yeah,
the
sure. So I know the regulations keep coming in. I don't know if you're
doing the blood withdrawal for the testing to confirm?
Right.
To be able
Drawing
to
the
say,
blood?
yeah, is it
Nurses are drawing.
the nurse that would have been dedicated to the patient?
So you want to have the least number of people obviously involved in it. I know that the nurses in our case, you know, change their shifts to do that on their own, which is a high level of professionalism, which we're all very proud of. And you want someone who is really very good at it, because for obvious reasons, if you prick yourself, it's a bad situation. So you got to handle the sharps like we should all the time, you know, in a very careful way. So it's routine practices. Be exceedingly aware of what you're doing. You've got all this extra PPE on again, right? And these pappers are noisy, so you can't hear people, you know, and that there's a communication issue that goes with those. And in the lab, what they did was to use the point of care handheld lab analyzers that we have, mostly in Trenton and Picton, but we can Bancroft, but they managed to do that inside a biosafety cabinet inside the lab. I thought that was really smart. That was smart. I thought that was pretty cool. And that's kind of where people are going with this. I think we invented something unique.
So one other question, suppose that only a single case comes in with this. What if you have, say, a whole air crew and all of their families who are exposed? How would you handle the multiple casualties?
Yeah, that was, you need to contemplate if that was possible. I think the project for Public Health Ontario with the ministry need to be planning for that, particularly for GTA, which is so much bigger. If you had multiple cases, and how would you handle that? And with CFB Trenton, it's not an unreasonable question to ask. And so with CFB Trenton, will still be worked on. We would have to pass it over management 1, 2, theoretically, and after that it starts to get pretty untenable. You're going to now, the federal government has mobile hospitals packed up, ready to go in 18-wheelers in strategic locations around the country, including Ontario. They're secret, nobody knows where they are. But anyway, they're probably in Tim Hortons trucks. We don't think it's Tim Hortons. It's really a mobile surgical hospital. And you know, they come. You know, that's where you go. You go to the local medical officer. You go to there'll be a conference call with the province. Who, you know, protocol will be the province. Then you know, the minister, deputy minister has to call the federal government. We just don't call the federal government directly. That'll really annoy people and not get you anywhere. And then you know, there'll be that whole enterprise. The big trucks come rolling down the highway and setting up in the parking lot somewhere. Really exciting. And I know they're working on that as well.
Dr. Zoutman?
Hi.
Hi, it's Tammy in Bancroft. So when you mentioned about the whole of the work that's going on with the emergency medical services, so the ambulances if they pick up a patient that's suspect, they can go in the appropriate facility. Is that just for our area? Is that Central East, the deputy director asking if they have a place to change when they come here and if people to get to pick up and all that?
Right. Right. So there's we're wanting local EMS for our counties that serve QHC to bring people to Belleville preferentially. And then there's the what do you do in the region? And there's still some discussion of what's our trigger to send somebody to Kingston. If they have clinical Ebola, they come in, they've traveled, and they're really sick with a fever, and they've got, you know, bleeding going on. They don't need a blood test. They've got Ebola. There's another one, right? So you're going to send them. You're going to call and make the arrangements, and you're going to send them. What about our case? Does Kingston want that? They probably don't, because it would be over the top. You know, so they're probably going to ask all of the peripheral hospitals to manage the cases that are not sick, and you're just waiting for a diagnostic result, which is what we do. I think that's reasonable, because I think it's too much for KGH to deal with. They've got their own flow gridlock issues. I think it would be just unreasonable to ask them to take, anybody who's traveled with ever get on an ambulance and go to Kingston to get blood work done. That doesn't seem like a good use of resources. But if they clinically look like it, even if you don't have a blood test. So we are communicating with EMS to sort our local issue out, but then you got to be cognizant you're working in a bigger system, so you want it to sort of work as part of the greater whole. For example, what would Rockville's point of view be on for Smith Falls? Between Perth and Smith Falls, as I understand, they have an emerge both sides. Yeah, so they got to sort it out too. So it just has to be consistent as opposed to one-offs. So there's a memo I have that I haven't sent yet to sort of say that, but I'm wondering if it's the right thing to do. I want to make sure that it's part of the whole system. I haven't sent that memo if you want. Because I'm not sure if it's the right, I don't want to be throwing, yet another moving part into a whole bunch of decisions. It's not part of the larger whole. So there's another conference call next Friday. I think it should come up there. EMS should probably be solved.
Can you comment on the readiness of KGH in their sort of very specific role?
Well, other than having worked there for an awfully long time and been responsible for those things, I don't know specifically. I know they're getting, you can imagine they're working real hard, and they've got good people and brand new ICU, which is lovely, and they'll be working on the space and on the protocols and training up the right people and doing very much what we're doing. Because the treatment of a patient with Ebola is just good, critical care. There's no specific treatment that's available yet. So they will be working on that. And then hopefully it comes, for their sake, I hope it comes, that designation comes with some resources, some money. I don't know, it often doesn't, unfortunately, from the ministry to help them, but I don't know that. That's a lot of work. It's been a lot of work for us. It isn't going to be any less for Kingston, equally the same. So anything we can do to help them as a region, we must do, because we're all in this together. Last call. Any from the North Hastings Family Health Team? I think you were on the call as well. Do you have any questions or comments? No. Great. Well, thank you all very much, and wash your hands.